Welcome, everybody. This is Suzanne Mackey from the School-Based Health Alliance. We're just gonna wait a minute or so for people to file in, and then we'll get started.
Students, please pardon this interruption. May I keep following?
Now I think it's a good time to just remind folks, if you have some noise in your background, please mute yourself. And you can unmute yourself if you have a question or want to speak up. And if you are in a place where you are able to use your video, please do so. We really want to see everybody if possible. Okay, hi everyone, we're gonna get started. This is Suzanne Mackey with the School-Based Health Alliance. Welcome to the first session of the Adolescent HIV Prevention Echo. So just a reminder to folks, please use your video if you are able to do so, and please mute your audio if your background is noisy. So the agenda for today, so first, we're going to get to roll call in a second, but I want to let everyone know that we have an exciting presentation from one of our expert faculty, Molly McHenry, who will be providing an overview of adolescent HIV infection in the United States, particularly the Southeast, and will address the roles of stigma, bias, and cultural humility. For our first session, just a reminder that we will not be doing case presentations, but we will be following up with each of you soon about how to sign up for a case presentation date and more information on the case presentation forms and how to actually submit a case presentation. So for roll call, so what we are asking of everyone right now is that you enter your name and the name of your organization in the chat box so that we can keep track of attendance. If you are with multiple people from your organization, please include all names of whoever's in your group. And if some of your colleagues are joining you later, please put their name in as they come in. So just a reminder to folks, I've sent out the expert faculty bio sheet, so hopefully you've had a chance to review who the expert faculty are. But I am so excited to provide you with such an amazing group of faculty to serve on this ECHO. They will each be leading sessions in their areas of expertise and providing feedback on your case presentations. And you can read more about them in the bio sheet, which is posted on Moodle. And so for today, we have the pleasure of hearing from one of our faculty, Molly McHenry, who is a family nurse practitioner with the Cincinnati Children's Hospital Medical Center. And now I'm going to pass it off to Molly.
All right, let me just pull up my slides. So the name of the presentation today is The Landscape of Adolescent HIV Infection in the US, Addressing Stigma, Bias, and Cultural Humility. So since this is the first talk that we're doing, I'm kind of trying to go over a lot of different concepts and then talk a little bit about where we're at as far as HIV surveillance data in the United States right now, as far as adolescents are concerned, and then talk a little bit about PrEP. But a lot of these things we're going to go into further detail as we move forward with the trainings. So here are the objectives. Describe the contributing factors to the disproportionate impact of HIV in the Southeast to LGBTQ populations and unique risks for adolescents. To examine the impact of HIV and LGBTQ stigma in my community and the role of my organization in responding to this. Assess the impact of my personal values and biases on my ability to provide high quality and appropriate care to reduce HIV and STDs in adolescents who identify as LGBTQ. So lots and lots of things. So I'm going to first start with talking about intersectionality a little bit. So intersectionality is defined as the interconnected nature of social categorizations such as race, class, and gender as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. So this definition is a little overwhelming when you read it, a lot of big words, but a way that I heard it described, which was really helpful, was to go over a case that actually happened in the United States in the 1976. So it's Gavin Reid versus General Motors. So at that time, there was a group of African-American women who sued General Motors, or attempted to sue General Motors, because at that time, General Motors was hiring a lot of Black men to work on the factory floor, and they were hiring a lot of white women as secretaries, but they were not hiring very many Black women, and the Black women were quote unquote last hired, first fired. So this case was brought up to kind of, ask the question, is discrimination compound? And unfortunately, it was 1976, so the case was not even addressed. It was dismissed before it could even be tried. So, but thanks to this woman, Kimberly Williams Crenshaw, who's a civil rights advocate and scholar, she has done a lot of work in intersectional theory and has kind of done a lot of the work in kind of bringing that idea to the mainstream, because of course, our identities are intersectional. They are for all of us. And with that comes, privilege and stigma, and sometimes both. So I'm going to talk a little bit about the role of stigma. So, we're talking about LGBTQ kids in general, adolescents, but I wanted to specifically go over this study that was done by the Human Rights Campaign about Black and African American LGBTQ youth, because as you'll see later in the slides, these are the young people who are most affected by HIV, seroconversion, and by far the most impacted at this point. So in this study, it was a survey study, so they asked a bunch of questions of young Black LGBTQ youth. 80% usually feel depressed, down, worried, nervous, or panicked, and nearly half feel critical of their LGBTQ identities. So if you think about how we're all seeing adolescents all day, it's a very complicated developmental stage in general. That's the baseline. This is the beginning of figuring out how to adult, which is a big job. So if 80% of these young people are, the vast majority of the time, feeling panicky, nervous, worried, and depressed, how are they able to engage in the really important work of figuring out how to be an adult? And that goes along with feeling critical of who they are, who they innately are, and critical of their LGBTQ identities. 67% of respondents and 82% of transgender and gender expansive youth have been verbally insulted because of their LGBTQ identity. Again, I'm assuming that most of this is happening at school. I mean, it could happen in any arena, but school is where young people spend most of their time, and if they don't feel safe, how can they engage with their work? How can they engage with their peers? 90% of respondents have experienced racial discrimination, and only 5% believe Black and African American people are regarded positively in the United States. Again, this is a major stressor, and the majority of the respondents, reported this stressor in their lives. 63% of Black and African American, transgender, and gender expansive youth try to avoid using the restroom during the school day. So right now at Cincinnati Children's, I am mostly working with transgender youth. And when I meet a patient for the first time, this is one of the main things we talk about, because so many of my patients are avoiding using the bathroom because they don't feel safe. They're getting bullied in the bathroom. And then that leads to very real medical complications like chronic constipation and chronic UTIs. More than 3/4 of Black and African American LGBT youth who responded to the survey have heard family members say negative things about LGBTQ people, and nearly half have been taunted or mocked by family for being LGBTQ. So this was a quote I took from the discussion of that study. Messages that reinforce stigma and shame, racist rhetoric from elected officials, and inequitable systems of care complicate the ability of Black and African American LGBTQ youth to fully express and explore their intersectional racial and LGBTQ identities. And basically I feel like what this statement is saying is it prevents them from being themselves. And how can you do anything in your life if you can't even just simply be yourself in all of the arenas of your life? So this was taken from a study in 2013 about stigma and HIV. I know the font is a little small, but it's a really interesting study for those who want to kind of dig a little deeper. But this is basically talking about intersectionality and social stigma and how it impacts people. And it talks about how there's kind of a macro level of structural oppression and then a micro level of what we sometimes call microaggression, and I'll go a little bit over what that means. And then at the bottom, it's moderators, so things that can help young people or any people overcome the stigma and the disparities, including empowerment, trust, social support, coping. It's really scary to think about all the barriers that these, well, specifically we're talking about young people face, but it's also helpful to remember that we can impact them in a lot of different ways to help them overcome all of these barriers and all of the structural oppression that they face every day. So I'm going to go over implicit bias a little bit. So implicit bias, sometimes called unconscious bias, happens when we allow our own attitudes, feelings, stereotypes, or beliefs to impact our judgment or understanding of other people. So, I think about this a lot. When I was putting this slide deck together, I just had a moment where I thought, like, how has my implicit bias affected me in the past week of seeing patients? And I definitely feel like it has. I mean, I grew up in rural Ohio. It was a predominantly white town. Luckily my parents both had lived in Cincinnati before they moved to that small town. So I was getting a little bit different messaging at home, but still it was like the air that I breathed all through my childhood was filled with racism and homophobia, actually. And it is a hard thing to untangle from your brain. And I can still hear that voice in my head, even though I ignore it and push back on it, but it's still there. And I think it's important for us to just even be aware of those voices and where we come from and how that affects us and how hard it is to deprogram ourselves. So what we consciously or subconsciously assume about our patients has an impact on the healthcare we provide. Implicit bias may contribute to a healthcare system that marginalizes and harms individuals and communities by perpetuating systems of oppression through racism, homophobia, transphobia, and many other things. This means us. So, I think it's helpful when I'm giving these presentations or hearing these presentations about these topics and learning about this, it's really helpful to kind of consistently try to look internal into what we're thinking and what we're doing, because nobody wants to admit that they have racist thoughts. Nobody wants to admit that they have homophobic thoughts. But I think until we address that internally, we can't face it. And I am a queer person and I still have, internalized homophobia, and, it's hard to look at that. It's hard to look at that, but it's so important so we can start to engage with it and really do the hard work of deprogramming it. So here's a little video that we're going to watch that talks a little bit more about unconscious bias.
Is there a remedy if I'm a physician or a nurse and I believe what you're telling me, which is I don't believe I'm racist or acting in such a way, but there are unconscious biases at work, can I unlearn them? Can I work my way out of it? And if so, how?
There are a number of strategies that have been shown to be effective. One of the basic override, well, I would say two things. The first thing is to realize that could be me. The typical healthcare provider, I had many talks to medical, nursing, and other health professional groups after the Institute of Medicine report came out. And the typical healthcare provider in the United States would say, I would never do that. I would never provide less pain medication to a black patient than a white patient. Whereas the evidence is clear that black patients get less pain medication with similar levels of conditions. So the first thing is to realize that could be me, and that people who have implicit biases are not bad people. They are just reflecting the culture and the beliefs that they were raised with. So that's the first point. The second big principle is the challenge of focusing on what we call individuation versus categorization. What is normal for human beings as we process information is to put things into categories. So I see you, and I don't see you as a unique individual, Don Berwick, but I see you as a middle-aged white male. I've put you in a category, and in my mind, there are lots of associations that comes with middle-aged white male. So it's how do you look at a person, at your patient, at your client, and see that person as an individual, and try to understand the individual context of that person, as opposed to instantly seeing them, which is natural, because that's how we deal with the complex cognitive information we have to manage every day. We put things into categories. It simplifies life. It helps us to navigate our social world. So it's normal for us to do that. So that's one general principle. There are a range of other strategies that have been shown to be effective. One is trying to put yourself in the shoes of the other. So you have a patient who was an elderly black male, and if you stop and wonder what his life was like, and what was it like for him to grow up in this society, and what are the things he encountered. So the extent to which you try to walk a mile in someone else's shoes, that is another strategy that has been shown to be effective. There's also a strategy that's called counter-stereotyping, which means you think that all women are weak. Well, could you sit back some days and just imagine what a strong woman would look like? Mm-hmm. And imagine that women could be strong. So those are a number, but they're a broad range of psychological strategies that have been shown in very careful laboratory experiments to minimize the occurrence of it. I would say two things. One is processes of implicit bias are more likely to occur when someone is working on the time pressure, so you don't have time to think. You just default to your social categorization processes. It's also more likely to occur when you're dealing with complex cognitive information. In fact, researchers point out that many of the features of a typical encounter between a patient and a healthcare provider, the ingredients within that encounter are some of the very factors that social psychological studies show maximize the processes of implicit biases operating.
I'll guess that fear can play a role.
Yes,
when you're
fear,
afraid.
anxiety also play a role, absolutely.
All right. So just to say something that they brought up that I think is really important for all of us, because I think most of the people on the call are clinicians, is that we never have enough time. There's a high level of anxiety taking care of people, and it is really hard to, I feel like every week there's like a new task I have to do during visits, and the length of my visits are getting shorter and shorter to do what I have to do. And it's really hard to then think about this other thing that we want people to do, which is to think about your own unconscious bias and think about, your thoughts of like homophobia and racism. And I think that can be really paralyzing. A way that I try to think about it sometimes is that I want to make room for my patients and for whoever I'm interacting with to let me know who they are. And I think that that's maybe a less intimidating way to think about this, is to just like be open to your patients telling you who they are and showing you who they are, instead of getting kind of pigeonholed into like thinking about if you're having racist tendencies come up, because I think that can just be so overwhelming and not really helpful at the end of the day. So I just wanted to talk a little bit about communities that are marginalized by healthcare. I'm focusing on these, but I'm sure that there are more, and this is just like a very brief overview. Disabled people, people of color, Indigenous First Nations people, LGBTQ people, which is who we're talking about, undocumented people, people who are currently or formerly incarcerated, and women in general. So this is a really great study that just came out in 2016 that I think a lot of people are talking about right now. The name of the study is Racial Bias in Pain Assessment and Treatment Recommendations and False Beliefs About Biological Differences Between Blacks and Whites. And let me just tell you, the next slide is terrifying, okay? So these are the questions that they asked in a questionnaire of the general population, and then first-year medical students, second-year medical students, third-year medical students, and residents. So I'm just gonna read a few. So Blacks age more slowly than whites. So of residents, 14% agreed with that statement, okay? These are people who are basically doctors. I mean, they're still being supervised, but Blacks' skin is thicker than whites. 25% of people, felt like that was a true statement. Blacks are better at detecting movement than whites, 11%. So I'm just reading the residents column, but I mean, the numbers are even higher in general population, first year, second year, and third year medical students. So, this is 2016. The study was done in at University of Virginia. I'm not sure if that's where all the participants were from, but, this feels really scary and sobering to me. And what they found, of course, is that those who endorsed more of these false beliefs showed more bias and were less accurate in their treatment recommendations. So basically, like in the midst of this like opioid crisis where people are being like, overprescribed pain medication, Black patients are being undertreated for their pain. So, it's just so scary. And then these are some historic things that I think people are probably aware of. Tuskegee Study of Untreated Syphilis in the Negro Male. And I like to say that the last widow of a quote unquote participant in this study died in like 2003. So this is not ancient history. It ended in 1972. So, there are definitely people who are still alive who were directly impacted by this, who had a parent who was maybe, impacted by this study. And then, Henrietta Lacks, who was a woman in her 30s who had cervical cancer, and there was a sample of her cervical of the cancer taken without her consent, and now it is used in thousands of research labs throughout the world. And actually, before I became a nurse, I did cardiac research, and I used HeLa cells. It was like 2004. I had no idea, but we are participating. We are participating in these things. Native American Indigenous people, the forced sterilization of Native women by the US government in the 70s. So definitely people still alive, directly impacted by that. And then this was a really great presentation. I went to a physician in Boston who uses a wheelchair, did this study, which is amazing. Very scary, but really helpful, I think, as a clinician to think about how people who are differently abled, how our preconceived notions and implicit bias affects the care that we give them. So this shows that people with disabilities, in this study at least, were less likely to get a pap smear. And it even breaks it down into different disabilities, which I think that this study was really interesting. And then of course the AIDS epidemic, which we're kind of talking a little, we're talking about HIV seroconversion today. These are two articles taken from the New York Times. The one on the left from August 3rd, 1987, when doctors refused to treat AIDS patients. So these are physicians refusing to treat people who are in dire need of medical care. And then just a few months later, November 13, 1987, the AMA had to make a ruling that doctors were obligated to treat AIDS patients. So, again, this is not that long ago. This is the late 80s. And then I mentioned the term microaggression, and hopefully everyone has at least heard the term, but these things that I was just talking about, all these studies, all these forced sterilizations, decreased rates of pap smear. Those are kind of like macro level kind of oppression and structural oppression. But there's also, microaggression, which is defined as statement, action, or incident regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as a racial or ethnic minority. So you can see, I don't know, the font, the lettering is not that bold in the pictures, but the signs say, where are you really from? And then the second one, why do you sound white? And then the third one, oh, you don't speak Spanish. And the last one, yes, I am legal. So, these are things that people are dealing with, many, 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 many times a day. And, the isolated incident is maybe not that horrible, but compounded multiple times a day, every day of your life is definitely going to wear on your mental health and probably your physical health too. So cultural humility is kind of what we are, aiming for instead of, cultural competence, which is, I think, kind of the last wave of how we were trying to figure out how to really help people, overcome their implicit bias and be more aware of how they're interacting. And this also talks a little bit about that introspective piece that I was talking about before. So cultural humility, it's a process that requires humility as individuals continually engage in self-reflection, self-critique as lifelong learners and reflective practitioners to redress power imbalances to develop mutually beneficial, non-paternalistic partnerships in care. So it can be really painful to engage in self-reflection and self-critique. I work with trans kids and I've been working with trans kids for 10 years now, and I still sometimes get someone's pronouns wrong. I definitely still sometimes find myself assuming things about my patients. And, it's really painful after that, and when I'm aware of it, I try to apologize in the moment. Apologizing is painful. Thinking back on those moments is painful. Unpacking those moments is painful. But I think it's so important if we really want to do the work that we're trying to do, which is, address our patients' real needs and create a care plan that's going to address them. And I feel like the more you do this, kind of the less painful it becomes. It still feels hard, but, we're all human and we're all impacted by, the society that we grow up in. We're all impacted by, the racism that is embedded in our culture and the homophobia that's embedded in our culture. And that's okay. But, really taking the reins and looking internal, I think, is a really good start. So this is, I really liked this kind of graphic about cultural humility. So on the left, it has patient-centered medical practice. So relationship-based care, like connecting and again, what I was saying before, making space for your patient to let you know who they are. Witnessing on behalf of patients, so kind of like trying to understand their life and seeing them. Focus on individual rather than groups. And then reflects the reflexive anthropology side. So, we have a different understanding of culture, awareness that of the universality of culture. Everybody has a culture. There's no default, there's no baseline where there's this group has no culture and then other people have culture. Everybody has a culture. Providing training in ethnography, and then, cultural humility then coming down at the bottom, hopefully is going to improve patient-provider relationships and decrease marginalization of minority groups and help us just to have better outcomes with our patients, just to really be able to address their healthcare needs. I'm just going to briefly go over terms. I hate when people go over terms, so I'm just going to go over a few. You can look back on them. I also included a link, I think, if you want to look at more terms. There's so many terms. So I'm just going to go over cisgender and transgender. So transgender, probably everybody has heard, relating to a person whose sense of personal identity and gender does not correspond with their birth sex. And then cisgender is the term we use denoting or relating to a person whose sense of personal identity and gender corresponds with their birth sex. So trans people, like somebody who's male assigned at birth, but is, feels internally female, that's a transgender female. Somebody who is female assigned at birth and identifies with that gender is cisgender. So I identify as cisgender. I identify with my sex assigned at birth. And it's good to use these terms and not talk about transgender people and then normal people, or transgender people and regular people. And also for the science geeks out there, cisgender and transgender, cis and trans are also terms used in organic chemistry, if that helps you remember, for functional groups. I don't know. know if anybody remembers way back to organic chemistry. Sexual orientation is the sexual concept of one's self based on feelings, attractions, and desires. So, you know, we've been throwing around the LGBTQ, and that stands for lesbian, gay, bisexual, trans, and then Q is usually queer or questioning, in my experience. And then there's a plus because often there are other letters also. And, you know, I think sometimes people get like annoyed about like how long this is getting, the like all the letters. But I mean, it's because we're trying to capture a lot of people. There's a lot of diversity. There are a lot of people that are atypical in many, 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 many different ways. So I think that that's what it's trying to capture. You know, a lot of young people, myself include, I mean, I'm calling myself young, I'm 37, you can decide if I'm young or not. I identify as queer, and that definitely I have, you know, friends who are LGBT, who are in an older generation than me that have a hard time with the word queer. My mom definitely, it took her a long time to feel like I was not saying something that was like crazy or blasphemous, but that is definitely a term that has been reclaimed. Sexual behaviors, so men who have sex with men, a lot of times when you're looking at like scientific studies, that's the term used, MSM, and women who have sex with women, WSW, and those terms are used because, and we'll talk about this a little bit more, behavior does not always line up with sexual orientation, and it's important to remember that as a clinician, so we're you know, doing the correct testing that needs to be done. So terms to unknow, I just put a few. So homosexual, you know, it's definitely a term that I think the connotation is very medicalized, and I definitely don't know anybody personally who still identifies as homosexual, and I definitely would like try to avoid using that term. And then like homosexual relationship or homosexual couple, you know, you can just use like relationship or couple. And then sexual preference. So preference kind of denotes that this is a choice that people are making, when really we believe it's something that's innate. So sexual orientation or orientation is probably better. I wanted to include transvestite just because it's an outdated term, again, that was kind of used and kind of oppressively by the medical community for trans people and people who quote unquote try cross-dress. And then when I was showing my wife these slides, she was like, will you please just like put in alternative lifestyle? You know, I think that that's an outdated term. I don't hear people use it that much anymore, but it's like, you know, the question is like alternative to what? Like what are we even talking about? So, you know, again, I don't want people to get like overwhelmed and anxious about what terms they shouldn't be using because, you know, it's a lot. It's a lot to remember. It's a lot of practice. We're all going to make mistakes. You know, I make mistakes all the time. I use the wrong words all the time. And you just apologize. You just apologize sincerely and keep it moving and try to like do it differently next time. But there's the link that I was talking about with terms that we're no longer using with LGBTQ folks. And then I just wanted to put in a little reminder that gender identity and sexual orientation are separate and often unrelated. So who people are attracted to is unrelated to how people feel about their gender. And then sexual orientation does not always line up with sexual behaviors. And we actually have a case study that's going to kind of unpack that a little bit. And here's the case study. So it's a little wordy, but I'm going to read it. So here's Lee. So Lee presents to the health center for his annual checkup. The health center includes sexual orientation and gender identity questions on the registration forms. Lee notes that he is, quote, heterosexual/straight on the intake form. Later during the exam, the primary care provider asks as part of the sexual history, are you using condoms or comfortable with the idea of a partner getting pregnant? Lee, who has only had male partners for the past year, answers, I've been sleeping with men lately. The primary care provider then asks, oh, it says here that you're straight. You must have filled out the form incorrectly. Lee responds, no, I didn't. So what assumptions did Lee's primary care provider make and why was it incorrect? So now is the time where you guys can, you know, we really want you to encourage to speak up. And when you talk, I think when you talk, your screen is gonna be this, oh, or maybe not because I'm in the slideshow, but you can just unmute yourself and speak up and tell us what you think. For people who are a little more shy, you can definitely use the chat function. But really our goal in this echo is to really have a conversation because we're all going to learn from each other. And, you know, we work in a very diverse settings and we want to hear you know, about people's experiences and where they're coming from and how they would do something. So please feel free to speak up. So what do we feel like?
I just want to jump in and just remind folks to unmute yourself if you have a comment. And if you are feeling shy, you can also type your responses in the chat box and we will discuss those as well.
This is a judgment-free zone.
Yes, don't be shy. We're here to learn.
Hi. This is Tessa from
Hi, Tessa.
Florida. Hi. So I guess the heterosexual and straight is kind of misleading and outdated. I mean, I guess these young folks are not categorizing themselves in that way anymore. So as providers, we're so outdated in that sense, like forms that we use, they're not updated with, you know, the current situation or the current terms. Does that make sense?
Sure. I mean, I would say, yeah, they're definitely my experience with intake forms as a you know, patient myself is that there are a lot of outdated terms. However, I feel like in this instance, I don't even know, there might not have been a term that he felt more comfortable using, but you know, well, I'll let it, does anybody else have, I don't want to hog the mic here. Does anyone else have anything that they want to respond, or I'll just step back?
Molly, one thing I would say, this is Renata, one of the experts.
Whoever's speaking, Renata, can you turn your volume up?
Can you hear me?
It's kind of faint. Can you
hear me now?
It's still a little low. Is there any way to turn your volume up?
It's all the way up. Can you hear me?
Okay, that's better, yeah.
Okay. All right. So one thing I think that individuals should just remember, which this case really highlights, is that sexual behavior does not always match orientation. And so I often like to show sort of intersecting circles that are overlapping, but they're not synonymous, meaning they're not in line with one another. And so individuals, it's not uncommon for individuals to say, I'm straight, and still be engaging in sex with someone of the same gender. So we've got to unpack our minds to rethink about and not put people into boxes, because when we put people into boxes, then we actually place our own biases and our own assumptions on those individuals. And behavior, so orientation really includes that attraction, behavior, and identity, but they're not always synonymous with one another. And so to respond to Tessa, it may just be that he actually identifies as straight while still has sex with men. So trying to keep those categories separate will help to make sure you have a really comprehensive history for the youth that you're caring for.
Anyone else want to pipe up?
I was also, hi, Jen here from Ruth Ellis. Can you hear me okay? All right. So I was also going to say that he may not have identified with any of the other choices due to internalized homophobia or not being just able to say like he identifies as being gay. Maybe it was just gay or straight, and he identifies as something more fluid or more comprehensive. And so he's just recently started having sex with men according to the case study. So maybe he still personally identifies as straight and is figuring that out, and a category that was more broad or more gray wasn't available for him. So he just selected what he was most comfortable with at that point in time.
I'm gonna read something somebody put in the chat. So the provider assumed that because he identified as straight, he would only ever have sex with women. I think this is a natural assumption, although his response is a good reminder that we should not assume that people's behavior always matches a certain definition. And then the next, and then someone else put in the chat, he possibly did not understand the term heterosexual. So yeah, that's also totally possible. I mean, it's interesting, sometimes I use terms with my patients that I think that they're gonna know and they don't know them, but they're like doing the thing that I'm asking about. So it's good to remember that terms are not all universal. And I would say when I first read it, I thought like, what would I have done in this situation? And I think, you know, I think it's really valid that like the clinician looked at the form and somebody marked straight and he was a little surprised when, you know, I don't think that that's like horrible to be like, oh, okay, you marked straight, so I made an assumption. I think like kind of where it went not great is when he was like, oh, you must have filled it out wrong. Because I think that that's really like cornering someone and continuing to make that assumption. Like now it's like a double assumption. And then I think it would be hard for a young person to kind of like push back on that.
Hi, this is Mikey down at University of Miami. My internet cut out, so I had to like switch computers really quickly. But did anyone say the assumption that the provider assumed that that Lee was a cisgendered male?
No, no one said that, but that is great. Yeah.
Yeah. So that was the first like assumption that popped into my head of if the, you know. But then that takes me back to my stereotypes of this assumption that straight people only have sex with the opposite gender, right? But you know, but it definitely factors in that we might identify with something else and also think that straight people have sex with the opposite gender. But so just that complicated algorithm of of identity.
Yeah, because I definitely think the vast majority of intakes forms in the United States right now do not have like a gender, like male, female, other, trans, blah, 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 blah. I think most forms just have male and female still. So definitely, I feel like that's a great point.
The intakes don't, but a lot of EMRs now are asking for like preferred names at least, which I think is a step towards that.
Anybody else want to add anything or have any questions, or you feeling ready to move on? Okay. Uh-oh, somehow I got back to the beginning. Hold on one second. Uh-oh. Sorry, having some issues here. Okay. So I'm just I think that we actually addressed all of this, but I'm gonna read it. Lee's primary care provider assumed Lee identified as gay because he has sex with men. Although we commonly think of people who have same gender partners as being gay or bisexual, studies have found that as many as 10% of men who have sex with men may identify as straight. This apparent discrepancy between behavior and identity could be due to the stigma attached to being gay and/or cultural variations in sexual identity. For example, some cultures do not recognize gay identities. Some define gay men only as those who appear to act in traditionally feminine ways, and some feel that the term gay only applies to white people. It is also possible that Lee is in the process of coming out, but is not yet ready to identify as gay, bisexual, or another sexual orientation. For this and other reasons, it's important to routinely ask about sexual orientation and gender identity. And then I think that we kind of addressed all of these. And then we added asking about people's gender identity, or you know, that part I think was you know, good to add. So when he hears that Lee has sex with men, it is, however, acceptable for the provider to ask about sexual orientation again. So yeah, this is what I was saying. I think it's fine to like, you know, be a little like, oh, I was confused because you marked this, and but not to continue to assume. And then we have a second case study. I'll read this one. So Marley, who identifies as transmasculine, is being prepped for a gynecology exam by a medical assistant. The assistant says to Marley, please change into this robe with the opening in the front. You need to remove your bra and panties because you're due for a breast exam and pap smear. So what did the medical assistant say that might make Marley feel uneasy? Anybody want to take a stab? Either you can just go ahead and start talking, or you can use the chat function.
Can you go back one slide, please? So
Oh yeah, yeah, totally.
I mean, I think it's important for any healthcare provider, from, registration person to medical assistant to, other provider, advanced practice provider or physician or whoever it might be, RN, to, which maybe it happened in this scenario because we just have this small little snippet, but just to always ask, if the patient has gone through this type of examination before, and to just let them know the typical procedure for that, and letting them know that it's okay for them to always say whether or not they feel comfortable or uncomfortable. I think that a lot of times in working with many medical assistants and LPNs in the clinics that we're in, I think that a lot of times we all tend to get into the routine of how certain things are supposed to go. And so this is probably the exact same way that the medical assistant approaches any other patient that's going to be going for a gynecology exam. And so to them, they're standardizing the way that they might interact with all of their patients. And so it wasn't something that they're trying to purposely make someone feel uncomfortable, because the objective line of it is that this type of examination needs to be done. And in order to get that type of examination done, I need you to wear this robe the appropriate way. But I always think just checking to make sure that they've had some sort of, whether they've had this particular examination or procedure performed in the past, and what their experience was with that is important to know. I work with a lot of kids that have never even seen Western medicine physician before, and so it's always important for me to sort of gauge, like, if they've, what their potential exposure has been to a healthcare provider or a particular type of exam. And I always, explaining what the procedure process is before ever asking someone to, undress or disrobe or anything like that is very crucial.
I'm going to read a few things that people wrote in the chat function. So patient may provide, by calling her underpants panties. Yeah, definitely panties is a pretty gendered word. I feel like it's also just like it's kind of like a weird intimate word, maybe that's just me. And then the next one says many transmasculine patients prefer the term chest over breasts. Does anybody want to comment about that last one? Anybody have experience working with transmasculine patients and doing exams, genital exams and top exams?
I do. I have some experience doing pap smears and chest exams for trans guys. Probably about 60% of the patients I see are trans, and of those 60%, about 80% of them are trans guys. And they much prefer for me to say chest tissue, like the comment had said. Some of them have other terms they like to use, and we usually discuss that like in the beginning of their visits when I first meet them and get to know them. It's one of the things we like to talk about. Also for vaginal exams, a lot of my clients prefer that we say front hole versus vagina. And then again, some have specific terms that they prefer that we address. So that's been my experience. A lot of people are very anxious about vaginal exams. So I like to bring up the fact that a pap smear is due like several appointments in advance to have people have time to get used to that idea. And then in some cases, people have even needed to have some medication, like a small dose Xanax. So they bring a partner or a family member with them so that they can have the medication prior and have somebody else be able to drive them home after.
Yeah, that was really, those were some helpful comments. I would also say that I think it's just good practice to just mirror your patient's language in all kinds of ways. I try to ask my patients pretty consistently when I'm going to be doing these kinds of exams, how they refer to their body parts. And, you know, I see my patients pretty consistently, so that eventually they're like, Molly, you ask me this every time. But, you know, it's important. And, you know, I definitely have trans male and trans masculine patients who use the term vagina and they're like, whatever, it's a vagina, that's what I call it. And then I have patients who do use other terms like front hole. And, you know, I'm just happy to use whatever terms they're using. And I think it's okay. It can feel hard initially when you start asking those questions. It can feel awkward, but I think it's just, it's helpful to just ask those questions and hear what terms they use and just try to mirror that language. And that's what's going to make them most comfortable, I think. Anyone else have any questions, thoughts, anything they want to add?
I was just going to say that I think Jen hit it right on the nail on the head. I really think that a number of the patients I see experience a lot of gender dysphoria, particularly around their body parts. And so trying to unpack how much gender dysphoria, how much anxiety they have before, and as much as possible trying to prepare prior to the visit is really helpful to engaging and creating a safe space for our trans patients particularly. So I don't think that sort of we have to stop just here's a gown and leave the room, but thinking about, you know, what the implications of that are and how to prepare them so that it's not a scary exam is really important.
Anyone else want to add anything before I move on? Okay, I'm gonna keep rolling here. So we kind of covered that. So, you know, kind of gendered language, bra, breast exam, panties. You know, those are terms typically associated with female gender. We talked a little bit about dysphoria. Yeah, I think people had great answers. I think we covered everything. So Marley, so this is what could the medical assistant have said instead? Marley would likely feel more respected if the medical assistant used words like underwear and chest that apply to all genders and anatomies. The medical assistant could have said the doctor will be performing a chest exam and cancer screening. You should wear a robe with opening in the front. In addition, medical providers should ask transgender patients what words the patients use to describe their external and internal organs. So I just wanted to say something here. You know, in this example, it's a medical assistant, but, you know, a lot of you are working in school-based health centers, so you probably have pretty consistent staffing. But, you know, we're all working with different people all the time. And definitely, like, I try to foster an environment where if, like, somebody hears me saying something, like if a coworker hears me saying something that was probably not the greatest, they can approach me and I can approach them and just like not like judge each other about these things, because we're all learning, you know, culture changes, societies change, and it can be slow moving. So, you know, I think kind of trying to foster that environment where there's just like open dialogue about how we talk to patients will benefit all of us and ultimately benefit our patients. So here's a list of resources, and I think you all will have access to the slides. So I'm going to just do a brief HIV overview and a PrEP overview to end. Again, they're going to be like specific presentations that are, you know, go way deep into these topics. So this is just like kind of a broad strokes thing. So I'm going to start out with this slide. So this was a projection that came out by the CDC. I think it was April 2016. Many of you have maybe seen this. So this is the projection that the CDC is saying the likelihood of African-American MSM, men who have sex with men, of being exposed to HIV in their lifetime. So as you can see, it is 1 in 2. That is a 50% chance. And I'm going to talk a little bit more about this, but you know, this is not, there have been multiple studies showing that it's not because of different sexual, doing things different sexually or using condoms less frequently or more frequently, whatever. There's really no difference as far as that goes with the white MSM counterparts. It is really a failure of the medical system and a failure of, you know, a racist society. So, you know, there was a lot of discussion. I was working in Boston at the time. We worked with a lot of young people who were either HIV positive or at risk for becoming HIV positive. And this was like very devastating for us to see, to kind of face this reality. So I just wanted to include some comments that were made by people who work in, you know, the Black HIV, they work in, you know, Black community with HIV prevention. So Phil Wilson, the president and CEO of Black AIDS Institute, something he said around the time is that if we fail to end AIDS in the Black community, we fail to end AIDS. And then this is Daniel Driffin, who is the co-founder of the Southeast HIV AIDS Research Project. So this was in a really great article called Black Men Reject Lifetime HIV Risk Assessment and New CDC Report. It was in the Georgia Voice. It's a great article. I encourage all of you to read it. I think it was very helpful. So this is a quote from that article by Daniel Driffin. I want folks who read the report to walk away knowing that we are not in this epidemic due to our sexual proclivities. This epidemic we are facing is a direct response to systemic issues such as a lack of insurance, education, employment, and access to friendly and respectful treatment, and the list continues. So I highlight access to friendly and respectful treatment because it is right there next to lack of insurance, education, and employment, which are huge things. And he is saying lack of access to friendly and respectful providers is equally as huge as these like huge oppressive systems. So I think that we can't take for granted how much our demeanor and our rapport affects our patients and the care that we provide them. So I just wanted to briefly go over HIV screening. And again, I just wanted to say we're in all different states, we're in all different kinds of counties, we're in all different kinds of settings. So, you know, the procedures that you do might be a little different. So this is just in general about HIV screening, you know, currently. So HIV up until 2006, if you were going to do an HIV test on somebody, you had to have them sign a consent. Since 2006, it's considered opt-out, and you no longer have to provide pre and post test counseling. You certainly can, and it's great if you can, but you don't have to. They found that it was actually a barrier, that it was required to do counseling. You know, a lot of people were just choosing not to get screened because it was so time consuming. So the most current HIV test is the 4th generation antigen antibody test. And it comes in a rapid form and serum. So I think that in general, they're equally effective. The rapid might be a little bit less effective. Somebody can chime in here if I'm wrong. And I think the window is 15 days. So any exposure that happened in the 15 days prior to having the test will not show up. But that's pretty good. I mean, the one before this, I think the 3rd generation was maybe 6 weeks. So, you know, it really cut it down. Again, anybody can chime in and tell me if I'm wrong. I'm bringing this from my memory, which is not always great. So the communication of results in person versus phone or email, it's really great to be able to tell people in person, not on the phone or via email, that their test came back positive. It's also creates, you know, at the clinic that I used to work in, we would call people if their HIV results came back positive. We would call them and tell them they needed further testing, but we didn't want to tell them over the phone that they were HIV positive, because a lot of our young people, you know, not the majority, but some of them would, you know, become acutely suicidal. But then a lot of my patients, when they would get that call, would kind of know that their HIV result came back positive. So it can be tricky to convey these results if you're not doing rapid testing. And in some places, rapid testing is not an option. So CDC recommends screening people for HIV at least once, all people between 13 and 64, all pregnant people, and at least annually for sexually active men who have sex with men. So again, just a very brief overview. So this is the HIV Care Cascade. I'm sure many of you have seen it. This one is from 2012, so it might have changed a little bit in the past few years, but I'm guessing probably not a ton. So on the left, the blue bar is the total amount of people who are HIV infected in the United States. And then as you move to the right, kind of the, I don't know what that is, taupe bar is people who are diagnosed HIV positive. So, you know, people who are aware that they're HIV positive. And then the green is people who are aware they're HIV positive and linked to care. And then the like periwinkle or whatever is people who are retained in HIV care. And then the darker blue is need antiretroviral therapy. And then the darker pink is on antiretroviral therapy. And then the light pink is adherent and undetectable. So, you know, this is always like so hard to look at, because I just feel like we have a lot of work to do. We have a lot of work to do. You know, that's a small fraction. What is that, like a fifth of people who are HIV positive in the United States are adherent to medication, and their viral load is undetectable. So, and then this is specifically, rates of HIV broken up into regions. And since we're kind of focusing on the Southeast, this actually just is like the South, so it might include some of the Southwest also. So this goes by MSA, which is, I always forget what that means. It's mean statistical area. It's basically how we define population dense areas like cities and suburbs. So basically, if you look at the South, the first number is the total number of people that are HIV positive in different regions. So you can see that the highest total amount of people that are HIV positive are in the South. So then you can see the rate per 500,000 in MSA. So it's kind of a complicated chart, but on the left two columns, the furthest left two columns, those are the most population dense areas. So you can actually see that the Northeast, the highest rate of HIV infection is in the Northeast in population dense areas like New York City and Boston. And then the next one is kind of more like the density of like suburbs, maybe the next two columns. And then you can see the rate in those density areas are 253 per 550,000. And that actually, the South becomes at that point, the highest rate is in the South. And then in non-metropolitan areas, which are rural, again, the rate is the highest in the South. So definitely the rate of HIV for the most part is highest in the South, the southern parts of the United States. And I don't remember what states they defined as the South in this study. So then this was, the CDC did a brief on HIV in southern USA. So this was specifically about barriers to HIV prevention and treatment. And these are wordy slides, so I'm just going to read them. I didn't really know another way to convey it without just having a few wordy slides in a row. So diagnosis rate for people in the South are higher than for Americans overall. 8 out of the 10 states with the highest rates of new HIV diagnosis are in the South, as are the 10 metropolitan statistical areas with the highest rates. And you can see I put a little map in here that shows that the dark blue is the highest rates of HIV infection, and you can definitely see the Southeast has the highest rates, and then you can see kind of the states in the Northeast that are population dense are also high rates. So the heavy burden of HIV in the South is driven in part by unique socioeconomic factors. Income inequality, poverty, and poor health outcomes have long been more widespread in southern states compared to the rest of the nation. Southern states generally continue to have the highest numbers of people without health insurance. The 4 states with the highest proportions of people without health insurance are in the South: Texas, Oklahoma, Georgia, and Florida. This was 2016, so this may have changed a little bit, but I doubt it's changed that much. Cultural factors may also play a key role. Issues such as homophobia and transphobia, racism, and general discomfort with public discussions of sexuality may be more widespread in the South and can lead to higher levels of stigma, which may limit people's willingness to seek HIV testing, care, or prevention services. Another challenge is that southern states have not yet widely adopted new HIV prevention advances like the 4th generation HIV antigen antibody test, where the acute infections are most easily transmitted. So I forgot to say this, but the 4th generation, maybe a lot of you already know this, is very good at detecting acute infections because it actually tests for an antigen and an antibody simultaneously, and the antigen is present in the blood very early on after an exposure. So you can kind of tell if somebody's antigen comes back positive and their antibody doesn't, that they're probably they've been acutely exposed, which is helpful to know because that's when the rates of HIV virus are the highest and they're most likely to pass on the infection. So then this is another projection from that same study as the one that showed 50% of Black MSM will likely be exposed to HIV in their lifetime. So this is broken up by transmission groups. So again, MSM is the highest, 1 in 6, followed by women who inject drugs, men who inject drugs, heterosexual women, and heterosexual men. But by far, it's MSM, men who have sex with men. So diagnosis, so there's a few graphs in a row. I also get like annoyed when people do a lot of graphs, but I think these are helpful in just like a little broad overview. So diagnosis of HIV infection among adults and adolescents at age of diagnosis. You can see the highest rate of diagnosis per age group is 25 to 34, which is a little bit older than the patients that we're all typically seeing. And then the second is 13 to 24. But what I like to think about is a lot of what is leading to this high rate of diagnosis in 25 to 34 is already happening, is already impacting people when they are adolescents, 13 to 24. And it might be that they became HIV, they seroconverted when they were younger, but didn't get tested until they were older. But definitely, you know, the burden is on the younger demographic. So diagnosis of HIV infection among adults and adolescents by transmission category. So you can see like they're all kind of on a slight decline, except male-to-male sexual contact is on the incline. It's increasing. So the rates of infection are increasing in the United States right now among men who have sex with men, which I think some people don't realize. And then rates of diagnosis of HIV infection among adults and adolescents. And then this is broken into age again. And you can see that like 45 to 54 years is kind of on the decline, but there's a little bit of an increase both in the 13 to 25 years. You can see that there's like an increase as of 2013. And then again, in the 25 to 34, there's an increase. And then 35 to 44 looks like it's flattening out. Diagnosis of, I think this might be the last one. Oh, no, I think there's one more after this. Diagnosis of HIV infection among men who have sex with men at age of diagnosis. Again, you can see, you know, the demographic that we're working with, 13 to 24 is on the incline, is on the increase, and 25 to 34 is increasing at an even more rapid rate. So,
question, Molly, can I
yeah,
ask? Sorry.
Yeah, of course.
So those graphs ended at 2014. Do we have data from the last like 4 years if that has continued or changed? Do you happen to know?
It may. My assumption is that it has. I could not find more recent surveillance data that looked nice, but it looked nice in graph form. Like I could find some like studies, but no graphs. But my assumption is that it's continued to be on the incline. And I can definitely, I'm going to email Suzanne a resource list, and I can definitely, if I find more recent surveillance data, I'm happy to include that in that email for everybody to take a look at. But so these are all from CDC. This one is actually from 2016. But a lot of the slides, oh, that's from CDC also. Yeah, so you can also look up on CDC to see if they have more recent. It can take a while for surveillance data to get updated. Yeah.
Molly, there are updated slides on the CDC website that are up through 2017.
Oh, great. Oh, that's good to know.
Share those resources with the individuals that are on the call today or on the echo. Today.
Can you see if it looks like those demographics are still on the incline?
Yeah, so I would say you'd have to go back a couple slides, but
I would go back.
That, particularly, well, the epidemic is the same. So among the highest rates of HIV occur, particularly among men who have sex with other men or same gender loving men, particularly African American same gender loving men, with rates as high as 60%. In adolescents and young adults. What I would just note in this particular slide, we have continued to see sort of this purplish line continue to increase. In some cities, there's been actually, you're gonna talk about PrEP, but in some cities, there has been a deep downward trend of new cases, but particularly for the 13 to 24-year-olds and the 25 to 34-year-olds, the increase, particularly among young same gender loving men and males who have sex with other males, has continued to increase despite declining in other groups. So we've seen declines in individuals who do inject drug use, for example, but not in the population that's shown here. So it's very similar. I would say if you go back one more slide, it may have been two, I can't remember, but those rates that were broken down by age, yes, this one, I want to say it's closer to 40% are among the 25 to 34-year-olds. And I can, you know, pull that up. So really half of the diagnoses occur among those individuals that are less than 30.
Thank you so much for sharing that. And did you say that you shared that in the chat function?
I don't know how. I don't know how I can share that, but I can try to figure it out.
Oh, or you can send it to Suzanne. I'm sure she'll email it out to everyone.
That might be, or we can send the link out to the CDC website.
Okay, great. Thank you so much for that. I'm just going to go back. So this was the one I was talking about, I think, last. Most HIV diagnosis in the United States for most affected subpopulations. So this is kind of, you know, a little intersectionality. So Black MSM, this was the rate in 2016, how many people actually seroconverted or that we are aware of that seroconverted. And I think, and again, somebody please tell me if I'm wrong, but I think the Black and African-American population in the United States is maybe around 17%. Maybe I'm wrong. I'm really pulling it off the top of my head.
I think it's 12 to 14%.
Yeah, about
Okay.
13%.
Okay, thank you. So definitely, you know, very disproportionately, the Black MSM community is very disproportionately affected. You can tell on this slide. And then just a very brief PrEP overview. Again, we're going to talk a lot more about PrEP for people that have questions. So PrEP stands for pre-exposure prophylaxis.
Molly,
Yeah.
I hate to interrupt you, but I just have a question. I noticed on all the CDC graphs that there's no information on transgender women.
Right.
And we know that the rates are high among transgender women of color. So does CDC just not collect data on transgender men and women? So is that the issue?
They do not break them out. And I think, and I'm, as you can tell, I'm totally open to people telling me if I'm giving people misinformation, so please pipe up if I am. But I think that the CDC was kind of preparing to start breaking out trans women and trans men into various studies that they were doing until the change of the regime. And transgender was a term that was not even, I mean, it was encouraged to not even include that in the research, that word and the research that they were doing. So, you know, I think we were on the verge of having that breakout, and I didn't include any of this, but there was a, I think in 2015, there was a survey sent out to trans-identified people, and per self-reports, like 1 in 17, I think, Black trans women are, you know, said that they were HIV positive. It might have even been higher than that. I didn't include the slide, but it is like a very high rate. And then I think also per that study, it is, you know, trans women are like way more likely to die of AIDS complications also. And I'm happy to give that. I can't do it right now because I'm overwhelmed by technology and don't know how to do it while I'm not sharing my screen, but I'll send the link of that study to Suzanne and she can share it with everybody. It's a really amazing study. And I think it actually, for states that participated, it breaks down, it has like specific comments and statistics about states. Individually, I know that Ohio is one of the states that it did that for, so it can be really helpful to kind of get an idea of what's going on locally for you.
Great, thank you.
So add to that, so I actually used to work at CDC in the HIV surveillance branch, and when I was there, we were in the process of starting HIV behavioral surveillance with transgender women. And so that project, I believe, ended last year. So there should be data coming out from that study. You should starting to see that hit journals kind of later on this year. That information should be forthcoming to have a more granular look at trans women specifically. Mm-hmm. The other thing I wanted to kind of go back to was on the, you know, the infamous 1 and 2 study. Important to include as a corollary to that. So I was actually CDC when that study came out, and there was a lot of internal conversation about sort of how to frame it. And unfortunately, the media, when they, you know, picked it up, and also when it was presented in journals, you know, kind of there was a, you know, clause after the, you know, 1 and 2, if we do nothing. And so it's really important to know that that projection based on sort of kind of prevention technologies, no new kind of advancements in treatment. You know, it doesn't kind of take into account PrEP coverage, doesn't take into account kind of what we know about U equals U, undetectable equals untransmittable. So I think oftentimes those types of studies have the ability to kind of suck the air out of the room and create this sort of epidemiology as destiny sort of narrative. And I think it's really important that we know that, we have the ability to sort of impact that information. So, and I think it's really important that when we're presenting this information, I think all, because we're clinicians, we can do this, but particularly when, you present that information to communities, how, really devastating that can be. And to remember that, it's not enough to just present that information, but to also give people tools so that they can, protect themselves. And so you're not just kind of giving this information and saying, as a young Black gay man, you're going to get HIV, which is what it sounds like. It's really about how do we empower people to have the tools at their disposal to make sure that they protect their health. And so I just wanted to throw that out there as something else that we should be thoughtful of, particularly if we're going to present this information to non-clinical audiences.
Great, thank you so much for that. That's really helpful to remember. Yeah, it can definitely be devastating to see that graph. And I don't know, as far as I know, that projection hasn't changed or CDC hasn't updated it, but there is a lot of room. I mean, in a lot of ways, we know the things that need to change. We know, and there are a lot of tools that can be implemented. I mean, even this echo that we're doing, disseminating information and sharing our practices is a way that we can, hopefully change that. So thank you so much for that. And then I'm just going to do a very brief prep overview. Yep.
One other
Oh,
thing.
of course. Yeah.
You had shown the graph. The country, and so I think that participants should also know about the new strategy, which is in the epidemic, where HHS, it was announced let me take a step back, it was announced during President Trump's recent.
Can you speak up a little bit, Renata?
Sure.
Can you speak up a little bit?
Sure. So in the epidemic, I'm not sure if people that are on the ECHO have heard about that, but that was announced recently in February of this year in the State of the Union address. And so really it is meant to allocate funds to communities that need it most. And there are 48 counties, 48 cities over the US. A lot of them are concentrated in the South. Baltimore actually happens to be below the Mason-Dixon line, so we're one of the southern cities rather. And so really, I think there is at least a potential to really try to leverage resources in communities that need it most. I get sometimes disheartened by that purplish blue picture of our country and where the epidemic is. And I think we have an opportunity to try to really make a change and try to engage communities. They're really looking to work with Ryan White programs and service providers that have not necessarily always been at the table. So I think it's an opportunity also for schools, people that are caring for youth in schools, to leverage potential resources in their communities that might be receiving such funds.
And did you say there was, oh, I was getting some echo. Did you say there was a name for that?
Yes, it's in the epidemic.
In the epidemic, okay.
Or ETA, ETE.
Okay.
But you can, people can go onto onto hhs.gov and find out strategy. The strategy actually are, as Justin described, U equals U. So making sure that people know that undetectable equals untransmittable. So if you're taking medications regularly and your viral load is suppressed, then you can't transmit the virus to others. There's good data, there's good evidence that demonstrates that. To protect is another strategy, which you're going to talk about around pre-exposure prophylaxis. Making sure people know that there is a biomedical prevention method that is been shown to protect against HIV as much as greater than 97%. Almost up to, depending on if you're taking it regularly, right? So so that there are different strategies that are laid out in the epidemic that are specific to how monies will be allocated and prioritized.
Is it like, can you apply for grants? Is it that kind of thing, or it's just like a regional?
It's still being worked out, actually, sort of mechanism. And it's also really contingent on the budget request. So, the strategy is available. It's out there. If you go to hiv.gov, you can read all about it. That is sort of the plan. But again, any funding is contingent on sort of the budget approval, which has not yet happened. So.
Okay.
And some of the monies are being distributed to Center for AIDS Research sites that where the RFA or the call to action is specific to working with communities that are the target communities. And some of the monies will be distributed through local Ryan White or community-based programming, but I don't know if it's clear how that's going to be.
Okay. Okay. Thank you so much. That's so helpful. Anybody else have any questions or comments? Okay, I'm gonna just go over the PrEP slides real quick. So pre-exposure prophylaxis. So right now, PrEP is mostly used synonymously with Truvada, which is the name of the brand name of a medication. However, there are many more PrEP options in development, including an injection that's I think good for 3 months, just like Depo-Provera. And then there are other modes like a vaginal ring. As far as I know, none of them are FDA approved yet. Some of them are in, even at University of Cincinnati, they had an injectable PrEP study that just closed. So there are a lot more options that are kind of in the chute that are hopefully going to be available soon. And then here's kind of just like a pictogram of all the different, the font is really small, but you can see what the active drugs are. There's many different active drugs that are in these different modalities. There's oral pills, there's vaginal gel, vaginal ring, vaginal film. So there are a lot of different options. I think that there actually might be a second pill right now that's FDA approved for PrEP for people who can't tolerate, for people who can't tolerate Truvada, I think, and somebody, pipe in if I'm giving misinformation, but hopefully there'll be a lot more options soon. And again, the Care Cascade, and then I wanted to just everyone remember what the Care Cascade looks like. And then this is the PrEP Care Cascade, and I don't remember what year this was from, but it kind of mirrors the HIV treatment cascade as far as the people who potentially need PrEP, the people who are aware and willing to use PrEP, able to access healthcare, receive PrEP prescriptions, and are adherent. So kind of similar to the HIV Care Cascade. So this is just talking about PrEP and also PEP, which is post-exposure prophylaxis, which is, what post-exposure prophylaxis started for needle sticks for medical care workers, which is also available, but this is just talking a little bit about the difference between PrEP, which is pre-exposure prophylaxis, and PEP. And I don't know if anybody is prescribing PEP in school-based clinics, but I'm sure that that'll be talked a little bit more about in future talks. So then there's a few different decision tools that I think are really helpful. This is one that was being developed at Fenway Health when I was there. So it's kind of similar to, I don't know if anybody uses the birth control dot graph that shows how many people will end up getting pregnant on the various methods of birth control, but this is similar to that. And then there's a few there's some apps that you can use that patients can take themselves to assess if PrEP would be helpful for them. There's some clinician decision tools that you can use, and there are quite a few, I think, at this point. And the ones that I've seen are beautiful graphics and just a few questions. It doesn't feel overwhelming. It's very approachable. So those can be really helpful too for anybody who's interested. I can look up a few, or if anybody else knows of any that you want to share in the chat function. To help people start thinking about prescribing PrEP. So then I just wanted to briefly say, so there's the HIV Drug Assistance Program, which every state has, which is, I think, a combination of state and federal funding. And then, there's, a hope and a plan to have something like that for PrEP. I think a few states, Massachusetts is one, when I was living there, they were starting to develop their PrEP DAP program to help people afford, for people who are uninsured, maybe people who didn't want to use their insurance for various reasons, to be able to afford the PrEP medication. And I think at this point, we're going to have a poll question. Is that right, Suzanne?
Yes, just give us a moment while we launch it. Oh, it's been launched. So folks, just take a few moments to think about the questions and respond. And make sure that you pick all of the options that are listed that apply to you.
It's only letting us select one option.
If you have more than one option, feel free to just write it in the chat box and we'll make note of it.
Yeah, so sorry, unfortunately, you're only able to pick one option, but pick the option that is your top option. And then if you want to type in the chat box what some of the other concerns around PrEP are that you have, and then we'll have a little discussion about it. Okay, thanks everyone for participating. And Molly, are you able to see the results of the poll or no? Oh, okay. So yeah, let's share the results of the poll to everyone. And since I know it doesn't capture all of your concerns because you're only able to put in one option. So it looks like 6 participating school-based health centers currently are providing PrEP, which is great. Among the main barriers, lack of awareness about PrEP, lack of clinician confidence and or competence, concern about cost and or insurance coverage, patient confidentiality, concerns around parents and guardians, and then concerns that there might be a stigma from your school or community that PrEP is being provided in this school-based health center environment. And then concerns that the sponsor organization might not be in support of it. So there's definitely a lot going on there. Molly, I was thinking it might be helpful maybe to hear from some of the sites who currently are providing PrEP, just what your experience has been, because I would imagine that even if some sites are currently doing it, that you still have barriers or have had barriers in the past to getting it started up. So if any of those 6 sites want to jump in and just share a little bit about what your experience has been, I think that would be helpful, and how you've managed to overcome some of these barriers. Anybody want to jump in?
Sure, this is Nicole. I'm at a school-based health center in Washington, D.C. One of the students that is on PrEP has set up a delivery system through the pharmacy, and he gets 3 months supply at a time, and that's helped make sure that he has his medications without any gaps, even before he's run out of his current supply. So that's been really helpful for adherence.
Thanks, Nicole. Anyone else?
Nicole, may I ask how old your patient is?
He's 19.
Okay. And was he started on PrEP after being 18 years old?
I think he was started when he was 18.
Why did you ask, Mikey?
I asked just for, I only have one particular patient right now that I think could really benefit from PrEP, but being under the age of 18 years old has been a barrier so far. And so I'm just curious to learn more about, and maybe we cover this in future sessions, about navigating insurance companies and trying to get patients, the confidentiality when it comes to starting PrEP. And one of the programs here in South Florida is that if the patients are under 8, and they provide free PrEP through the Department of Health, but they have to have parent consent if they're under the age of 18 to actually start, or parent or guardian consent.
Yes, so I think we'll go into this in detail at a later time if I'm
Cool.
correct. But, one, it is FDA approved based on weight. So as of 2018, pre-exposure prophylaxis was approved for anyone that is 35 kilograms or greater. So that's about 70 pounds or so, a little bit more than 70 pounds. So that they didn't specifically approve it for adolescents per se, right? So the language is not necessarily specific to adolescents, but it's inclusive of adolescents. So yes. It's no longer not approved from an FDA perspective in only adults. It's approved in adolescents, so you can prescribe it. Now, what you're alluding to and what you're describing is that as far as minor consent laws exist throughout the country, there's variation regarding minor consent laws. And so you really do need to know what your minor consent laws are in your state to know what services you can provide to those adolescents without parental consent, right? So some states, there are specific laws that allow adolescents to consent for preventive services, whereas other states do not have that specific language. However, a lot of providers provide PrEP under the auspices of STD and HIV treatment and care, right, and prevention, right? So meaning that we wouldn't necessarily just treat someone for an STD and not give them condoms, right? We would do both, right? So a lot of providers do them together, but it does actually, without those laws in place, some insurance companies do not necessarily want to cover PrEP in those states without parental consent, even though it's FDA approved, because they're worried about sort of the ramifications of that, and that just varies by state. And then, there's also the other aspects of explanation of benefits and EOBs, and how do we make sure there are other protections in place for adolescents, just in general. And you alluded to cost as well. So those are some some challenges. You're in a red state, so you have your own specific challenges down there in the South.
We do.
Where are you located in Florida?
I'm in Miami.
You're in Miami. Okay.
Yeah.
That's a progressive area.
It is a progressive area, but they follow the rules that are sent down from Tallahassee.
Okay.
I believe that there is, and I can do some searching on this, but I think that there was a recent paper, I want to say out of Brian Mastance's group at Northwestern, that kind of did a scan of these different kind of policies with respect to adolescent consent for HIV. So I will do some digging, and if I do find that paper, I might be misremembering it. I can share that as a resource. So
that'd be great.
Yeah, and it's always changing. So that's the tricky part about a paper, because I think the paper will be a great resource, but it's always ever changing. The Guttmacher Institute is actually a wonderful resource around minor consent laws. Particularly, I don't know how robust they've gotten into PrEP, for example, or HIV prevention, but they do include a very nice breakdown by state of what the laws are regarding contraception, STD treatment and care, reproductive services, substance use, mental health, that are specific to the needs of adolescents, and keep it very up to date. So, for example, Maryland, we just passed that youth can consent for preventive services without parental consent, particularly for PrEP. Yes, and so it does vary state to state, and things are always changing. And I would suggest that here's an opportunity. You could advocate, right? Go down to your local Senate and advocate for expansion of services in your state.
Oh, Renata, you know that's already happening.
I'll say I was just in my experience prescribing PrEP. I started prescribing PrEP when I lived in Massachusetts, so it was like so easy. Everybody had health care, all the health care's covered, all the health care, it was always covered. All of our patients, our patients would come in if they were uninsured, we could get them insured that day and start them on PrEP. It was very easy, and it was before it was FDA approved for kids under 18, but my institution felt like taking the risk, and we were prescribing for kids under 18. Now I'm in, I guess, a purple state, which, I'm in Southern Ohio, right on the Mason-Dixon line. And it's definitely, there are a lot more barriers, some things that we've done that have helped. We usually work with one pharmacy that helps, at least our kids who are 18 and older, because we're not prescribing under 18 right now, and that's another story. But for our patients that we prescribe PrEP to, we have a pharmacy that we've created a relationship with that helps our patients get it covered. They know about drug assistance programs and things like that. And we don't have to consistently call them to help advocate for our patients. They're just doing it. So things like that can be helpful, making connections in the community. Does anybody else want to share about their experience prescribing PrEP, either barriers or hacks or experiences with, individual patients, trying to help them out?
So I've never had a patient that wanted to be on PrEP not be able to get it funded, either through Gilead or using the copay card or their assistance program. Or their Medicaid. I'm in Michigan, and so Michigan Medicaid is pretty generous. It's a $3 copay. If our clients are uninsured, the biggest difficulty I have is having people bring the documents that they need for the Gilead program. So say they're part-time employed, getting their 2 paychecks is really the hardest part for me. If someone's unemployed, that's just a matter of filling out the form. And Gilead has always been very prompt, and I've always had really great success. The biggest barriers, like I said, were if it was dependent on the client to bring some documentation. That's been the biggest holdup for me. But activating copay cards, I have clients do that right there with me. If they have private health insurance, we sit on the phone, they answer the 10, 15 questions. I have paper copay cards that I've been given by the rep that they, you know, use the number on it, whatever, we activate it. And then they either take it to their pharmacy, or we use our in-house hospital pharmacy at Henry Ford and I give them that copay information, and then the refills just get delivered to the health center. So for payment, I really haven't had a lot of trouble because of Gilead's generous programs. Some of the issue I do have is with, like everyone else has, with adherence. So sometimes our younger clients have trouble, you know, with follow-up appointments, making them for transportation reasons or what have you. So, you know, adherence to either testing, and then sometimes adherence to medication because they've missed the appointment and so they haven't gotten their refill, because usually they're getting the refills from the health center because they're delivered there, or because it's more confidential than having it out in the world. I'm school linked health center, I have to say, so I'm not inside the school. So people do need to have independent transportation to get to me. So that's a unique barrier that maybe a lot of people might not have because they might be inside the school. Yeah, I think that's it.
Because I just want to say, because you brought up transportation, I feel like that is a huge barrier coming from Massachusetts, where like I see, like, would see 12-year-olds like just on the train, whatever, like living their life. And here in Cincinnati, I moved away in 2004 and just moved back 2 years ago, and the transit system has not improved at all. In fact, like I feel like the bus system is worse. And even though I'm inside Cincinnati Children's Hospital, like in the center of the city, it is so hard for our patients to get here because of lack of good public transportation. And I think that is like plays a huge role in the disproportionate resources and healthcare resources that are distributed. And I didn't even think about that until moving back to what I like to call the Up South, which is what we call Cincinnati. Does anybody else like to share anything before we wrap up?
Hi, Tessa here. I'm in Delray Beach, Florida. Most of my population are Haitians, Guatemalans. They're coming in from the country. A lot of cultural stigma. That's a lot of barrier. A lot of my Haitian girls cannot say that they're sexually active because, you know, parents will throw them out. Even more so, getting on these medications, you know, getting sent to their homes or getting insurance bills and whatnot. So that's a big barrier for this, you know, women that I have. Even a barrier to get contraception, that's already a problem as well. So, you know, even more so with PrEP.
Tessa, do you feel like you have like institutional support? Do you feel like you have people on your team that are trying to troubleshoot with you and figure out strategies? Or do you feel more like you're alone in the trenches? You're making
I'm literally alone in this clinic. I don't have an MA. I'm by myself.
Mm-hmm.
We have other clinics outside from here. We are a third party in the school base campus, but support, I don't have much.
Do you have connections with other clinicians? Oh, sorry, Renata, were you going to say something?
I was just going to ask, where did you say you are? I'm sorry.
Delray Beach, Florida, West Palm.
West Palm, okay. Are you close to USF or?
No, that's Tampa. I'm actually from USF, actually. But no, that's 3 hours away from here.
Oh, okay.
Do you have, oh, sorry. Do you have connections with any other clinicians who are serving a similar population but might not be really local to you?
Not currently, because I moved here. I've moved around, so my network has not been that big.
Okay. I've just found in the past, when I've felt more isolated in my practice, that it's really helpful to connect with other people who are doing, which I know can be even hard to find those people,
right.
But to try to troubleshoot like the very, you know, kind of specific barriers that you're facing, just because it can feel so overwhelming. I don't know if there's a way to do that. I mean, we're here for you now.
Right.
Well, and we'll be here for you until December and beyond. But it does sound like some of the things that you're facing are very specific and would need really kind of specific strategizing around.
Right, like what I shared when I was filling out my application, this is the pilot program for the county. I'm the only one here in the county.
Yeah.
I bet New Broward or Miami is down south.
Mm-hmm.
Yeah, I mean, one thing, I don't know how your local health department is down there, but they may be a good resource for you.
Gotcha. Yeah, that'll be a good one.
At least, even if they don't have or are not providing services, most health departments are. And I said, as I mentioned, the ending the epidemic is specifically going to community and health department sites. So there will be a push to actually try to get PrEP to those populations that need it. And so it may be an opportunity that you could find like-minded people to think through how you might be able to address this for
right. Absolutely. Thank you.
At a minimum, the health department should also be able to link you to community organizations that are doing this work and doing testing and linkage and you know, engagement around prevention and treatment services. That's why I was asking where you are, because I know, for example, Metro Health is great, but they're located in Tampa. But they're, for example, they may, because they're in Florida, I'm happy to try to connect you and see if they're a community organization, but they might know others that are in your area.
Thank you.
And Tessa, I'm gonna steal your contact information from Suzanne if that's okay, and we should talk.
Absolutely, absolutely.
Just to remind everyone, you all have been given each other's contact information. The faculty have been given everyone's contact info as well. And I think it's just helpful to see where everybody is all over the country. And so if you guys do have questions that you want to take offline, refer to that spreadsheet that I sent out, and it's on Moodle as well. And I just want to point out on the chat box, Jen sent out a helpful blurb about explanation of benefits, and that it's not typically, they typically don't list meds prescribed or filled. Information is only made available to families if they ask the pharmacy. And then she also noted that most DMRs provide confidentiality for youth after age 14, so parents wouldn't be able to get that information unless they directly asked. So that is another level of confidentiality there. So.
And also from an EOB standpoint, youth, typically you're right in that medications are not included on the EOB. Some services are, or at least laboratory services are. It's a summary of the laboratory services. And so that's, I think, where the youth get caught into this predicament. If their explanation of benefit goes home and it includes that STD services or chlamydia test was sent, that may actually be provided to youth. Now, youth actually can request for that information not to be shared, but they have to know that they have to call the insurance company to request that that information specific to lab tests is not shared with the primary insurance holder.
And that's great. Yeah, exactly. And I'm not sure about other states, but in Michigan, we're very fortunate that we have the state laboratory for our school-based health centers provides voucher forms. So we're able to do testing confidentially, excuse me. So we're like really blessed in that. We can do the point of care HIV test. And if it needs to not be uploaded into the system, then it isn't, or we include it in a non-billed visit so that never hits the insurance. And then we are able to do the confidential gonorrhea, chlamydia testing through the state. So we're lucky there in Michigan that we have that, but that's definitely, I worry about with my prep starts with the CMP because, you know, you have to check the renal function. And so the CMP might hit the EOB, but it's kind of a benign test. So I always prep the kids with like, hey, your parent might ask, and you can say, oh, I went to health center to get checked out. She wanted to make sure I was okay because I wasn't feeling good, kind of explanation. But yeah, the CMP is the one I have the hardest time getting around because I can't send that to the state, and it's going to hit the EOB and it's going to go home.
Yeah. And then there are also Title X clinics that are all over the country.
Right.
And they're not necessarily associated always with Planned Parenthood that we always think about Title X.
Right. Yeah.
And they provide wraparound services for both females and males. And those are free or reduced costs, but they're all confidential.
Right. Yeah, those are awesome. The FHA or FHQC, FHCQ, you know what I'm saying. Yeah. We have a couple of those as well near us. So yeah, those really work. And as a side note, I don't know about everybody's minor consent laws, but in the state of Michigan, the Michigan Department of Health and Human Services has given us direction that if youth test positive for an STD, that PrEP then becomes part of the treatment plan. If they do not test positive but want to start, they have to go to a Title X clinic, and Title X clinics can start in youth under 18 without parental consent and no presence of an STD. But for my health center and other non-Title X clinics, if there is an STD present, then they're like, okay, go ahead, because the risk is there. But so that was just in the last 2 years. So other health centers might want to check with their local MD or their local DHHS and see if there has been direction, and if not, maybe advocate for them to make a decision on that.
Anyone else? I think we're about at 2 o'clock. Anybody have any other comments they want to get in before we end? I just want to say that this was so wonderful. We were a little worried that people weren't going to feel comfortable talking, but everybody, I feel like a lot of people were sharing. And, you know, Tessa, we were talking about you feeling isolated. I feel like it's so easy for clinicians anywhere. Even, I mean, I work in a huge children's hospital, and sometimes with the work that I'm doing, I even feel isolated, even though I'm surrounded by other clinicians. And I think that's why it's so important for us to do things like this, to connect and share, and it helps us feel less isolated, and it helps us with our practice. So I just want to thank everybody for sharing. I've learned a lot today, and I look forward to you know, seeing you guys once a month until December, and continuing to learn with you guys. I think that there's going to be a lot of people mentioned resources that I think we're going to try to send out an email, kind of pulling all of those things that we talked about, so we all have those in an easy reference point. And then, you know, we can always be in touch between sessions if people have questions, or if people, you know, once we start doing case studies, I think that that's when gets really interesting and helpful, because we're talking about specific patients. So hopefully, you know, we'll have some good patients to talk about, and we can all kind of think together about how to really address our patients' needs. So thank you all, and I'm going to hand it back to you, Suzanne.
Okay. Thanks so much, Molly. I'm feeling so proud of myself that I found like this amazing group of faculty who could lead our echoes, and such an amazing group of participants. And I really appreciate everybody speaking up and joining in. I think it just makes these conversations really rich and helpful. So I'm really excited about the next 7 sessions that we have together. And before we close out, I just have a few housekeeping reminders for folks. If you came in late, or you have not yet put your name and the name of your organization in the chat box, please do so, because we need to keep track of attendance. And CE credits, just a reminder, you must complete the evaluations in order to receive CEs from APHA. The slides and the recording from this afternoon will be posted to Moodle by tomorrow. If you have not yet had a chance to log into Moodle and check it out, please do so, because most of our communication going forward will be through Moodle. So the pretest, the evaluation pretest, which you all hopefully have completed by now, that will be on there. the documents that I've sent out, all of that will be on there. So please log into Moodle and check it out if you haven't already. And then a little bit more on CEs. If you have to miss a session, which may happen over the course of the next 7 months, in order to receive CEs, you need to watch the recorded faculty presentation and provide a reflection on Moodle. So we did not do case presentations for this first session, but going forward, we will have the faculty presentation first, followed by 1 to 3 case presentations, probably about 2 case presentations per session. The case presentation component will not be recorded. So it will just be the faculty recording that's available on Moodle, and that is what you have to watch in order to be eligible for CEs. And then once you've watched it, if you miss that session, you watch it, and then you provide a reflection in the forum. And then lastly, if you do miss a session, you need to watch the recording and submit your reflection within 7 days after the live session. And you also have to complete the CE evaluations as well within that 7-day period. And unfortunately, if you've missed both live sessions, so 3 of our topic areas will be a 2-part session. So it'll be part 1 month, and then part 2 over the next month. So if you unfortunately miss both clinical care sessions, live sessions, you will not be eligible for CEs, unfortunately. But if you miss one, you just go and watch the recording and complete the evaluation, and you'll be good. All session topics and dates are listed in the welcome packet and on Moodle. So if you want to look ahead and see what's coming up for next month. And then I think that's about it. So as Molly said, we will be sending out follow-up from this session and all the resources shared. And we will also be in touch with folks very soon to start planning the case presentations and have people sign up for a date and then talk through the case presentation forms and all of that. So we'll be in touch with everyone shortly about that. So again, I just wanted to thank everyone. I know that this 2 hours is a long time, but I think it flew by because this was a lot of great information and great conversation. And I just really appreciate everyone participating, and especially Molly for providing such an awesome presentation. We're all really grateful. So thank you to everyone, and we will be in touch soon. Thanks, bye.
Thank you.